almost forgot to start. Okay, so here we have the next thing, the name of this maneuver. Which maneuver? Oh, this one. I'm not sure. I will check and let you know. Okay, so there will be a higher heart rate in the patient. Why? Why would the patient have high heart rate? Why do you think, guys? To compensate for what? Why the patient have high heart rate in case of cardiac tamponade? Yes, the hypotension. It's a form of reflex tachycardia. Okay, the most important thing is to know about is something called pulsus paradoxus. They will describe it for you. They will not tell you pulsus paradoxus. Okay, so that we will explain in a second. But yeah, here is the thing I just told you about the electrical alterance. Notice here, guys. You can see here the R waves. One of them is low, one of them is high, one of them is low, one of them is high. Why? Because we just said the heart is just tumbling inside of the pericardium. So if you take a look at the ECG, you will realize that, wait a second, why these waves are going up and down? It does not make sense. So you can take a look here. It's going from here to here, and then from here to here, and then like this. So you can see like dop, loop, dop, loop, dop, loop, and like that. So you can imagine the heart is just going back and forth, back and forth, back and forth. So we call that electrical alterance, okay? And you can see it in any lead. Like you can use this lead, for example, you can see it as well. So you see one R wave has high voltage, another R wave has low voltage. It depends on the location of the heart. So the next thing here you can see is the following. So there is compression, here it is. ECG shows low voltage QRS and electrical alterance due to the swinging movement of the heart in the large effusion. So I just told you guys, it's like dop, loop, dop, loop. Okay, now we spoke about the Bixi triad, we spoke about the electrical alterance. What else is super important for us to know? The pulsus paradoxus. Okay, now I kept annoying you since the beginning of this class by asking you which chamber of the heart is the thinnest. Is it the left ventricle or the right ventricle? Right ventricle. Since the right ventricle is much more thin, you can imagine, guys, he will be more affected by the what? By the tamponade. So it goes something like this. When you inspire air deeply, okay, you do deep inspiration, you have more blood going to your right heart or to your left heart? Right heart. More blood goes to your right heart during inspiration. If more blood will be pushed inside of where? Inside of your right heart. Let's imagine what will happen. Okay, so more blood going inside of your right heart. If we imagine that this is the heart, more blood is being accumulating here. Good. So more blood is here. What else except of this more blood coming here is having a force over the heart? The external pressure, yeah? Which is the pressure from the tamponade, which is affecting the right ventricle more than the left ventricle, because the left ventricle is much more thick than the right ventricle, yeah? He's thick, he does not really care about that pressure. It exists, it makes him mad, but not that bad, you know? And between the left ventricle and the right ventricle, we have a structure composed of two portions, which is called interventricular septum. The interventricular septum has a membranous portion and has a muscular portion. Membranous, muscular. And when the blood accumulate inside of the right ventricle, and there is a pressure from the tamponade, the sum of these pressure, they have to go somewhere. Well, they can go to the pulmonary trunk. That is correct, but the pressure is massive. So the sum of all of this energy will go to this side. When it goes to the left ventricle, basically, there will be a shift of the septum to the left ventricle, okay? Shift of the septum to the left ventricle. And it will be more prominent on inspiration or expiration, guys? inspiration, because again, on inspiration there is more blood going inside of the right ventricle. So when you do, more blood comes in the right ventricle, so more pushing will occur. Okay, so when that occurs, what will happen? Well, let's imagine that, for example, you are pushing a cardiac output of, let's say you have, well, a stroke volume, let's say a stroke volume of 100 milliliter, okay? If you push this septum to this side during inspiration, like during that second, what will occur to this 100 milliliter? What will occur to it? It will increase or it will decrease the stroke volume. Remember, stroke volume is the amount of the blood going from the left ventricle to the outside. So it will increase, obviously. So initially there was 100 milliliter going from the left ventricle into the aorta, yeah? But now it was 100 milliliter plus the push created from the deviation of the septum. So it will be 100 plus a little bit from the deviation of the septum. Let's say it's 10 milliliter. Now the stroke volume has become much larger. So the stroke volume has become 110. Guys, maybe you remember when I kept telling you about the systolic and the diastolic blood pressure. So systolic blood pressure is mediated by what? Contractility, exactly. Contractility. So the heart controls the systolic blood pressure. The diastolic blood pressure, on the other hand, is controlled by what? The vessels. It's by the vessels, especially the arteriole. Remember about the precapillary sphincter I kept annoying you with. So the systolic blood pressure is normally 120. Diastolic blood pressure inside of the aorta, it's around 80. Okay, so if we say that the patient has higher stroke volume in case of tamponade, what will be altered? Is it the systolic blood pressure or the diastolic blood pressure? What will be changed? Yes, someone got it, come on. It will be the systolic blood pressure. Imagine, guys, you have more stroke volume. More stroke volume means more contractility. More contractility means more systolic blood pressure. Because who controls the systolic blood pressure? That is the heart. Who controls the diastolic blood pressure? It's the vessels. So in case of tamponade, it's a problem of the heart or the vessels here. It's a problem of the heart increasing the stroke volume and the cardiac output. Thus, the systolic blood pressure will be much higher, okay? During what? During inspiration. Why? Because you have increased the stroke volume. Why? Because you have, during inspiration, you have more blood in your right ventricle. Okay, how does that work? Well, more blood in the right ventricle lead to movement of the septum, interventricular septum, from the right side to the left side, which lead to a further pushing of the blood from the left ventricle into the aorta. So let's read what they write. Decrease in the amplitude of the systolic blood pressure by oh, I made a mistake. Okay. Again, let's take a look here. So there is post paradoxic. I made a mistake. I was like, something does not make sense. Okay, now it makes sense. So yeah, the person who wrote in the beginning, you were right. When we have again, I hate when I am wrong, but it happens. So when you have further breathing, the amount in the left ventricle will what will happen to it? First of all, the right ventricle blood volume will increase. That will push the septum. The septum will be pushed to this side. If it will be pushed to this side, what will happen to the preload? The preload will go down. Less preload. So the preload will go down. That will lead to less what? Less cardiac output. I made a mistake in the beginning. I was building on something wrong. So again, right ventricle, when there is more pressure in it during inspiration, there is a bulging towards the left ventricle. About a bulging towards the left ventricle will lead to less amount of the blood in the left ventricle during deep inspiration. When that occurs, that decreases the cardiac output. When that decreases the cardiac output, that decreases the systolic blood pressure, not increases it. I made a mistake, and again, if it does not make sense, I will explain it one last time because I made a mistake. So, the blood in the right ventricle, what happens to it? It increases on inspiration. So it pushes what? The intraventricular septum. So when that is pushed, the amount of the blood in the left ventricle, what will happen to it? It will decrease. So if the amount of the blood inside of the left ventricle is decreased, the cardiac output goes down. And when it goes down, what will happen to the systolic blood pressure? It goes down. Okay? So decreases in amplitude of the systolic blood pressure by around 10 millimeters of mercury during inspiration. And we said why inspiration? Because during inspiration, more blood go to the right ventricle. It's seen in multiple causes. One of them is the tamponade, but there is other causes, including constrictive pericarditis. Before speaking about constrictive pericarditis, I would like to show it to you. They like to show you a CT scan of it, okay? And on the CT scan, you need to be careful to be able to appreciate the calcification that it creates. So let's take a look at it. There is calcification, this white thing around the heart. This is constrictive pericarditis. Well, one more. Yes, you can see here constrictive pericarditis, and there is even a little bit of a fluid here, guys. This is like pericardial effusion. Also, you can see here the calcification. Okay, so in someone with the constrictive pericarditis, well, it can lead to similar problem. When they take deep breath, what will happen to the amount of the blood going to the right heart? It will increase. So let's explain why the blood goes inside of the chest more during the inspiration, because a lot of people don't get this idea. Like we keep telling more blood inside of the right heart during inspiration. But how come this is true? If we imagine that this thing is the lung, this is the lung, and this is the chest wall. So the chest wall always want to collapse to the outside. The lung always want to collapse to the inside. Okay, the alveoli want to collapse on themselves. When the alveoles collapse on themselves, we call it atelectasis, guys. Okay, and the chest wall always want to collapse to the outside. So this want to go out, this want to go in. They equalize with each other, and they create something called intrathoracic pressure. So the intrathoracic pressure, if you sum the two of them, it will be -5. This -5, when you deeply inspire, I'm like, so what happens? I have deeply inspired. Why this change anything? Well, when you deeply inspire, what will happen to your intrathoracic pressure? Exactly. So it wanna compensate. And how it does compensate? It brings the blood from other cavities, including the what? The inferior and the superior vena cava. Yeah? So if it brings it from the inferior and the superior vena cava, you have more blood going back to your chest. Okay. So let's take a look here. It's seen in constrictive pericarditis, obstructive pulmonary diseases as well, like croup, obstructive sleep apnea, asthma, and COPD. You must know why. So in case of obstructive pulmonary disease, if you take a look here and you see, well, here is right atrium, right ventricle, and then they go where? To the lung, yeah? So they are going to the lung, and here is the lung. If the lung, and here to the other side, we have what? We have the left atrium, left ventricle. It's here, let's imagine it like this. And they have the aorta coming out. Well, anyway, So let's imagine what happens here. In case of COPD, what happens to the pressure inside of the vasculature of the lung? In case of asthma, in case of OSA, which is like sleep apnea, all of these, yes. So the pressure in the lung goes up. When the pressure in the lung goes up, the blood has to go back. And when it goes back, it starts accumulating where? Inside of the right ventricle. And when you take deep inspiration, you bring more blood to your right ventricle also. So right ventricle has more blood coming from the lung, more blood coming from the inferior and superior vena cava. What it will do, it will push the septum of the heart from the right side to the left side, will compress the septum, less cardiac output, decreases the systolic blood pressure by how much? More than 10. If it's less than 10, that's normal. Okay, so COPD, we said asthma, OSA, which is obstructive sleep apnea, most commonly in obese people with a BMI over 30, and the group. Also cardiac tamponade, we explained that one in the beginning. So, here we have something called pulsus paradoxus. They like to show you this picture. This is monitoring of blood pressure during what? Inspiration and expiration. So, and expiration is in between. So, I hope it makes sense. Inspiration, expiration, inspiration, expiration. So, during inspiration, what happened? More blood inside of the right heart. What happens to the systolic blood pressure? It drops by 10. Why? Less cardiac output. Why? The intraventricular septum has been pushed to the left. Yeah? And now I expire. When I expire, what happens? Well, everything goes back to norm. So, yeah, there is less blood in your right ventricle and less bulging to the left ventricle, and everything go back to normal. So your systolic blood pressure go up again by more than 10. The main idea is to be more than 10. Okay, so the next thing I want to show you guys is regarding the picture. Both of them you can do it. Even like by the manual one, you can do it. And okay, let's imagine that you have a patient in front of you and you want to check that. He has a tamponade, you highly suspect that he has the Beckett triad, he has hypotension, he has like muffled heart sounds, he has all of that. Well, just for fun, we want to check it. We don't do it often, but let's say you want to do it. So how do you do it? You put the blood pressure cuff, okay? You inflate it. And you know when you deflate it, when it reaches 120, what you will start to hear? You will start to hear the sound, yes? Okay, so you start hear the sound at 120. Do not deflate it anymore. Keep it at 120. Tell him to what? Tell him to take a deep inspiration. It will disappear, the sound. The sound disappear. You cannot hear it anymore. Now start deflating slowly. When you deflate slowly, when it reaches 100, you will be able to hear the sound again. So you tell him to inspire and hold. Okay? So inspire and hold. You will not hear it initially. When you deflate and reach 100, you will be able to hear it again. So it's one form of maneuvers that you can do actually. Okay, so I wanted just to show you a tamponade picture. Chest x-ray. It looks quite cool and you must see that. See this? They have a common name for it that you must know. It's called what? The water balloon sign. So this is the water balloon sign, as you can see. Guys, in an adult, where should be the apex located in an adult? Is it right or left of the midclavicular line? Yes, exactly. So the midclavicular line is around here. So it must be 2.5 centimeters right to the midclavicular line. But this guy is absolutely somewhere else. And it's enlarging from both sides. Why? Because, well, tamponade will cover the whole thing. So it will give you this, we call it the balloon sign. You must be comfortable with the balloon sign. Yep. So let me send you the balloon sign. Okay. So that's it for cardiac tamponade. Our next topic is about bacterial endocarditis. Bacterial endocarditis, do not mistaking it with the topic regarding rheumatoid fever. These two are totally different, okay? So today we are going to speak about bacterial endocarditis, rheumatic fever, syphilitic heart disease, acute pericarditis, myocarditis, and vasculitides. And hopefully cardiac tumors. I am planning in finishing pathologies with you guys. So the next thing, yeah, it could be looking the same actually, pericardial effusion when there is, well, both of them have it, both pericardial effusion and cardiac tamponade, because the accumulation of the fluid is in the same sac, okay? So, well, here you go, water bottle sign, it's from your word. So, bacterial endocarditis. Bacterial endocarditis, we have the acute, we have the subacute, forms of bacterial endocarditis. So there is this mnemonic called Jones, and we'll speak about it in a moment. But before speaking about that, let's just have a random conversation. For those who did not do microbiology, it's okay if you don't know this. So if we have an IV drug user, which bacteria are you thinking about? Staph aureus. That's correct. Staphylococcus alone is not enough. You have to say Staph aureus. And which valve will be most commonly affected in an IV drug user? The tricuspid valve, because it's the first valve that goes after a vein. Yeah, they inject the blood inside of the vein. Bacteria goes from the vein all the way until it reaches the right atrium and hits. The first valve is the tricuspid valve. Okay, let's speak about someone who got endocarditis after some form of like prostate removal during surgery. So he had like a transurethral prostatic removal. Which organism are you thinking about? Well, if someone had a transurethral prostate resection, and after that, in a couple of weeks, he developed endocarditis. This is a common tricky question, and you must know that after manipulation of the genitourinary tract, you are at high risk of developing Enterococcus faecalis or Physium form of endocarditis. Let me show you this, guys, because they do ask it and they love to trick you about it. So if you see here, there is this enterococci, and they tell you if you develop a subacute endocarditis following a GI or genitourinary procedure, most commonly a transurethral prostatectomy. Okay, the next one. Someone who had colon cancer and then he has endocarditis. Like you saw colon cancer and then he has endocarditis. Bovis, also called a galacticus. Good. Someone who did dental procedure and then have endocarditis. Dental procedure, very dense. Yeah, dental procedure, like something with his teeth. And then he get after what? Bovis. Oh, bovis, you get it like if it's associated with someone who have colorectal cancer. Okay, so he has colorectal cancer, and you start highly suspecting what, and he have endocarditis. You need to know that there is association between the strep bovis and the colorectal cancer. So this is interesting because if you take a blood sample and you see a strep bovis in it, the next thing you want to do is a colonoscopy. Okay, so He has endocarditis, you know, you do blood culture, you find strep bovis, it's positive, and that's it, colonoscopy, you find a cancer there. Okay, so the last one I'm going to ask about now will be someone who changed the valve in his heart. If someone changed the valve in his heart and now has endocarditis, it is Staphylococcus epidermidis. Yes, exactly, Staphylococcus epidermidis. Okay, let's take a look now. So they write for us bacterial endocarditis. It can be acute, like Staph aureus. Keep in mind that Staph aureus is high virulence, which means that it sucks. It destroys the valve in a really bad way. And it can lead to large vegetation on a previously normal valve. You are like, wait a second. How come normal valve? Well, because it's highly virulence. Look, normally guys, the endocarditis affect already damaged valve or abnormal valve. That's why they like patients who have mitral valve prolapse. But in this case, in case of Staph aureus, he does not really care. He can affect a previously healthy valve. Guys, look at this tricuspid valve. See all of these vegetations? These vegetation are just Staph aureus. This is septic vegetation. And yeah, they come quite big. And the subacute form of bacterial endocarditis include very dense, but this one is low virulence. What does that mean? It will not affect a normal valve. It must affect an abnormal or a previously diseased valve, okay? So there will be smaller vegetation on a congenitally abnormal or a diseased valve. So congenitally abnormal, this is include what? MVB, for example, mitral valve prolapse, or someone with a bicuspid valve, or someone who's, for example, has coarctation of the aorta. You're like, wait. Why would someone with coarctation of the aorta have higher risk of endocarditis, guys? We spoke about it. Well, in case, yes, more stasis. In case of coarctation of the aorta, we had like that. Well, this is an aorta, let's say, and it's occluded somewhere like right here, and then it becomes big again. So in this area, there's a stasis, and the stasis, who loves the stasis? Bacteria. Bacteria, when she sees the stasis, like, she loves it, and she like, oh, my new home, and they start proliferating at that area because there is more stasis, more turbulence, so they pretty much like it. And because of the stasis, there will be hyperproliferation of the bacteria, and they start migrating all over the body, including the endocardium. Okay, so next. So they write for us, very dense streptococci can be a sequelae of dental procedure, and they have a gradual onset. Symptoms most commonly include fever. Why? Because it's a freaking bacteria. And a new murmur. Guys, tell me please, if you have a new onset bacterial endocarditis, will you have a regurgitation murmur or a stenosis murmur most of the time? Well, that's correct. It will be a regurgitation murmur. So there will be regurgitation murmur most of the time because stenosis takes time. And you can see here, Roth spots can be seen, which is round white spots in the retina surrounded by hemorrhage. Guys, you must know about the Roth spots. Well, basically, Roth spots are what? Roth spots are basically just a septic emboli traveling inside of your circulation, okay? And they go everywhere, including your eyes. So you can see them in your eyes. So look what they are doing here. So leading to minor infarct with a lot of hemorrhage around it, okay? We call it like a flame shaped, if you see it, like Roth spots. They are all over the place. Okay, so yeah, septic emboli. So they also can lead to Osler node and Janeway lesion. There is two ways to remember which one is painful, which one is painless. Some people say like Osler node, ouchie, ouchie, Osler. It's possible. I just remember that Osler is the man, he's painful. Janeway is a lady, she will never be painful, except for your heart. So Osler nodes, we have ouchy raised lesion on the finger or the toe pads. You can see them at picture C. So you can see them here. And also you can see the Roth Spots here, and you can see the vegetation there. So now let's speak why Osler is painful while Janeway is painless. Why do you think, guys? Why do you think Janeway is painless while Osler is painful? Well, Osler is a complex guy, while Janeway is more of a septic emboli, you know? So if what do I mean by complex guy? Well, Osler is caused by immune complexes. Yes, that's correct. And they travel inside of the body, and when they go and form the Osler node, they lead to local inflammation, okay? Because it's type 3 hypersensitivity reaction. And after the creation of that immune complex and the position of it inside of the vessel, it becomes inflamed, which is really painful. That's why Osler node is painful and Janeway is painless. Janeway is not an immune complex deposition, it's just a septic emboli. Okay, so Osler node, ouchy raised lesion on the finger or toe pads due to immune complex deposition. While Janeway, it's a small, painless erythematous lesion on the palms or soles. So the main thing here is painless, painful. Why Osler is painful? He's immune complex. Why Janeway is painless? She's just septic, nothing more than that. There is something called also splinter hemorrhages, which occur under the nails. So you can appreciate them here. You can see them here. Okay, so that's not that difficult. It's just like memorization stuff so far, a little bit of understanding. But you must know about some associations. For example, if we speak about endocarditis, it has high association with the glomerulonephritis. How come? Did you ever hear about something called well, there's multiple way you can have a glomerulonephritis. It could be due to the bacteria itself, or it could be secondary to the septic emboli inside of the body. But most likely it will be from the bacteria itself. Okay? So if we take a look also, you can have something called septic emboli. Well, septic emboli practically can go to any organ in your body and lead to infarction. Guys, do you know what is the most common organs to be affected by septic emboli? What is the most common organ to be affected by septic emboli? It's an important one. Yes, excellent, guys. So the main idea is it likes to affect the kidney. That is correct, but actually, the most common area is the brain. Why? Because it's just right there. It just keep going. It can affect the lower extremities as well. It can travel anywhere, but most commonly it goes first to the brain. Well, septic emboli. What does it consist of? What is inside of the septic emboli? Like a thromboembolism, we know it's a thrombus. Fat emboli, we know what is it. But what is septic emboli? What makes the septic? What makes this emboli? Exactly, bacteria. It's bacteria. So they also tell you it may be non-bacterial. So there is something called mesenteric or thrombotic. For example, in case of lupus, guys, the Lidman sucks in case of lupus. How can you differentiate it from other forms of endocarditis? It has something specific to it, like by shape, I mean. No, it's not the fibrosis. Well, first of all, obviously, it will not be septic vegetation, but the vegetation will be covering two sides of the valve. Like normally, in endocarditis, they only cover one side. But in case of Liebman-Sachs endocarditis secondary to lupus, they affect the lower side and the upper side. And if you take a histological specimen of them, they do not have bacteria, just immune complexes. Good. So, they can be secondary to malignancy and hypercoagulable state. Well, it means that there is, which malignancy is most commonly leading to hypercoagulable state, guys? Do you know it? There is one malignancy that cause hypercoagulable state. Pancreatic, exactly. And pancreatic cancer. Yep. And it has something called the trisocine. So what is this trisocine? It's basically a combination of thrombophlebitis in the lower extremity, mainly due to a hypercoagulable state. It leads to this migratory thrombophlebitis. Okay, you must know about this. Good. So the next thing here we have from Jane with love. Well, I remember back in that time we had Jones as the mnemonic. It was something like this: Jones, G-O-N-E-S. J for joint, so that was the arthritis. Okay. O, that was the heart. But wait a sec. Wait. I made a mistake. Jones is for rheumatic fever. This one is Jane for love. This is for bacterial endocarditis. So yeah, keep it here for a second. Stay here, Jones. For Jane is different. Bacterial endocarditis is not rheumatic fever. It's what I just told you guys. Do not make that mistake. Okay, so they have fever, Roth Spots. Roth Spots included in the retina. What is Roth Spots, guys? They are, what are they? What are they made out of, guys? Exactly, okay. And Osler nodes, we said they are immune complexes, thus they are baneful or baneless. Okay, murmur, is it regurg or stenosis? Okay, Janeway lesion. So in Janeway lesion, we said it's painless. So the anemia. Anemia is interesting. Guys, if I have two questions about the anemia. The first question, which form of anemia can you get in case of aortic stenosis? Well, if you have really severe aortic stenosis, you can get which form of anemia? Hemolytic, exactly. Macroangiopathic hemolytic anemia. Why? Because the blood, exactly, mechanical. It's mechanical. Because the blood cells, when they try to go through that stiff valve, they will basically be sheared, and that will lead to creation of anemia. Also, in case of bacterial endocarditis, you can get what other form of anemia? It's chronic inflammation, basically. So what do you think? Exactly, anemia of chronic diseases. Excellent. So an Albed hemorrhage, this is the Splinter Hemorrhage and Emboli that can affect many organs, as we said. So they require multiple blood culture for diagnosis, and if the culture is negative, most likely it will be one of these culture negative endocarditis. Guys, just for your future, you must know that we diagnose the endocarditis with two things: echo and the blood culture. You must see the vegetation or get a positive culture inside of the blood. If the culture was negative, culture is negative, but you clearly see all of the signs of endocarditis. And you are thinking, what caused it? Well, it could be Coxiella Bernati, which you need to know. You must know what caused it. Coxiella Bernati is mostly due to what? Feces. So yeah, it's due to feces. The major and minor criteria, wait for them. I will explain them in one moment. Yes, we do have them. Yes, we have to know that. Okay, so If we speak about Coxiella burnetii, you must know that it's due to cattle feces, okay? What about Bartonella? What gives us Bartonella, guys? Yep, kitty, exactly, from cats. So, you must know about these. They lead to culture negative. Guys, just for fun, what is the treatment of Bartonella? Come on, somebody should know. Well, look, let me give you this trick. Whenever a disease seems zoonotic, most of the time, not all the time, but most of the time, it's doxycycline, okay? For example, if I ask you Bartonella and you don't know, tell me doxycycline, it will be correct. If I ask you tularemia, you have no idea, but you know it's caused by rabbit, tell me doxycycline, it will be correct. If I tell you what else goes, Blake, you know the Blake, which comes from rat and stuff like that. If I tell you Blake, you have no idea, tell me doxycycline because it comes from animal, you will be correct. Good. So, mitral valve, Lyme disease, doxycycline, well, that will work as well. See, so most of the time, if it comes from animal, it will be doxycycline. Mostly it works, but sometimes it does not, so don't say I said about all of them. So, mitral valve is most frequently involved in the heart, and the tricuspid valve is most likely to be associated with IV drug abuse, because we said that. When someone injects IV drugs inside of his veins, the first valve to be hit is the tricuspid valve. Remember that the people who do drugs, the most common organism that they will get, yes, Staph aureus is one, because they use this freaking needle 20 times and it gets like infected. And the Pseudomonas, because yeah, it likes that humid environment, and Candida. Actually, this is interesting because to get Candida endocarditis is super rare. So to have it in such condition is just like amazing. So the next one, we just spoke about it. Here it is. The S. bovis, the Galacticus. They don't use the word bovis anymore, guys. They do not use bovis. They like to use Galacticus, because they know all of the student now has got this name already, the bovis. So they use Galacticus. It's present in colon cancer, okay? It's present in colon cancer. So if you see someone who has strep bovis and then in the blood culture, what you should do next? Colonoscopy. Okay, so staph epidermidis is in the prosthetic heart valve. Yeah, we spoke about that. And finally, native valve endocarditis may be due to the hay-sac. So this hay-sac, these organisms are rare, guys. You do not have to memorize them. Just to try to be familiar with them. Like when you see them, they look weird, so you know that it's one of these guys that basically non-common ones, okay? So they include Haemophilus, this weird name like for Actinobacilli, Cardiobacterium echinella, and Kingella. One of the important one actually is echinella. So guys, which animal bite can lead to echinella? Which form of bite can lead to echinella? A human bite, exactly. It's the only time you can get echinella, not an animal. Humans, if they bite you, they get echinella. Do humans bite each other? Well, yes, they do, but commonly you will not get it from a bite. For the USMLE, you must know what is a fist fight is. So some people who fight, who like, for example, in a bar, this is the scenario in the USMLE, and they have like this fist fight. They start punching each other, and one of them punched the other in his teeth. So the puncher, the person who punched the other person, see, it works. So the person who punched the other person, he will get his knuckles in his mouth, okay? So that person will be practically biting the person who like punched him. So karma hits, or also called echinella. So echinella hits. And when Echinella hits, it's really bad. Guys, if you get a human bite and you do not treat it and that person has Echinella in his mouth, which is a normal flora, he will get really bad cellulitis. You might have to amputate his hand. So if you see such condition, you have to give antibiotic prophylactically, immediately. So which antibiotic do you give? Let me see. If it's an animal, so which antibiotic? Exactly. So mostly it's doxycycline, but for the actual clinic, because a lot of them are young, we like to give amoxicillin clavulanate. Okay, but doxy works as good. Good. Okay, so the next topic is wait a second, guys. There is something called major and minor criterias. What are these major and minor criterias? These are a couple of criterias that help you diagnose what? Endocarditis. So the major criteria include two things: blood culture and evidence of endocardial involvement. It's using an echo. You will be able to see the vegetation. If you have, look what they write. If you have these two, done, you have a diagnosis, okay? Or if you have one of these two and you have three of these guys, okay? You have a diagnosis. This is more a step 2 type of thing, but I don't know why they are starting to ask this on step 1. But so you must know about it. You don't have to memorize every single one. The major criteria you must memorize, but the minor one, not really. So a first thing, like a predisposing factor, like someone who is an IV drug user or someone who has like a mitral valve prolapse. Temperature more than 38, vascular phenomena. What does that mean? Well, it's, for example, that someone had multiple septic emboli in his body, like this Janeway lesion that we speak about, or he has Osler lesion. So immunological phenomena, it is like having this Roth Spots or the Osler region. Microbiological evidence, so that includes like having positive serology. So he does not have here, he could have not positive serology here because it could be one of the organisms that can be negative. But when you check his CBC, leukocyte is up in the sky. So you start thinking about something due to a bacteria. So you must know about this criteria. Okay, so the next thing, that was, yeah. Well, if you speak about, you are asking endocardial evidence. Well, look, most of the time endocardial evidence in the Duke criteria, it's the endocardial vegetation. Look, if you look, see here, endocardial involvement, positive echocardiographic findings of vegetation, okay? Or a new murmur, but mostly it's the vegetation thing. That's what you are looking for. Okay, so for now, let's take a small break so I can get a coffee, regain my concentration, and continue. Okay, so see you guys in 10 minutes. Microbiology that you must know, you must master these points. When we say that something is beta hemolytic, it leads to complete lysis of the RBCs where you apply it on the agar. While if we say something is alpha hemolytic, it leads to partial hemolysis. Partial hemolysis on the agar, on the blood agar, appears green, okay? So partial hemolysis, green. Beta hemolysis will be complete hemolysis. The whole thing will disappear. It will be like white. Okay, now we go back. Speaking about, okay, I forgot that. My mistake. Okay, can you see it now? Can you see my screen? Okay, awesome. So here we have the following. We have, the beta hemolytic, as you can see here, you can see nothing on the agar, which means it's totally has been lysed, the blood. While alpha hemolytic is partial hemolysis, which will lead to what? It will appear greenish, yeah? Greenish is alpha hemolytic. Okay, now let's go to here. Okay, so rheumatic fever. It's a consequence of pharyngeal infection with the group A beta hemolytic streptococcus. It could be a late sequelae include rheumatic heart disease that you will have for a really long time, which affect the mitral more than the aortic, more than the tricuspid. Left heart first and then right heart. So why? Because which one is dealing with the highest pressure here? Well, mitral valve is not opening against the contraction of the left ventricle, which is ridiculous, you know, and that it's not opening against that. So higher pressure are first, the mitral and the aortic, lastly the tricuspid. Okay, early lesion in the mitral valve regurgitation, late lesion will be stenosis. You already told me about this. Most of the early lesions of the heart will be regurg. Late lesion will be stenosis. Stenosis takes a lot of time. Okay, so the patient has rheumatic fever. What's wrong with him? What will he have? He will have endocarditis. Okay, so what is the big of a deal? If I take a biopsy of that endocarditis, what I'm going to see? Bacteria? The answer is no. You are not going to see bacteria. And instead, you are going to see something totally different. The reason the patient gets the endocarditis is not the bacteria itself. It's an immune reaction. Thus, it's which type of hypersensitivity. Do not be tricked. If it affects the kidney, we say it's type 3. But if it affects only the heart and this stuff, and it causing rheumatic fever, it's a type 2 hypersensitivity reaction. So it's associated with Aschoff spots. What are Aschoff spots? They are granuloma with giant cells. You can see them in the picture here. So the giant cells is just one cell that have many nuclei inside of it. I don't like this picture. I will show you another one. But guys, before it opens, can someone tell me what giant cells are made out of? Macrophages, exactly. So you can see here the granuloma. And guys, tell me, do you remember when I told you caseating versus non-caseating granuloma according to the causes? I told you in case of causes that are not directly infectious, like this one is a type 2 hypersensitivity, it's not directly infectious. Thus, this granuloma, will it be caseating or non-caseating? Non-caseating, exactly. Okay. So you can see in these cells, you can have like this Aschoff spots and anti-Schoff spots. So exactly, no central necrosis in case of non-caseating. So this is the Aschoff spots. So what is this anti-Schoff spots? Well, here it goes something like this. The Aschoff bodies are granuloma with giant cells. We already saw that. There is something called anti-Schoff spots, which is like if you look inside of the Aschoff body, you are going to see minor bodies inside of it. These will be like an enlarged macrophages, like see, this is a macrophage, and we said already that the granuloma is made out of macrophages with an ovoid, wavy, rod-like nucleus, as you can see here in the red arrow. If you can see that, you are lying, I cannot. So, but you can see this one then. You can see this shape, it looks, see this wavy, they say it's caterpillar. Yeah, can you see that? Okay, good. So when you see that, that's this rod nuclei it has. Also, this patient suffer from the following. They have the following antibody to be positive. The first one is the anti-streptolysin O, which we used for testing. It's and they have high anti-DNAs. Guys, do not be tricked. It's not anti-DNA, it's anti-DNAs. Anti-DNA is positive in what, guys? Also lead to endocarditis, but it's different. Lupus, exactly. Lupus has an anti-DNA antibody that leads to endocarditis, but that's totally different. So yeah, DNAs, A's is here. Okay. Also, it's an immune-mediated type 2 hypersensitivity reaction. It's not a direct effect of the bacteria. That's why we have a non-caseating granuloma. Antibodies to M protein cross-react with the self-antigen. So we have formation of antibody against the M protein. And that formation of antibody against the M protein leads to what? To all of the problem related to the heart. You're like, wait a second. So you are telling me this M protein looks like myosin inside of the heart. And it's located in the bacteria. That's why our body makes antibody against the M protein of the bacteria, but it accidentally hits our heart and lead to carditis. Well, I can believe that. It's possible. Molecular mimicry, I can believe it. But how come it can lead to problem in the CNS? It does not make sense. How can M protein cross-reaction lead to a problem in the CNS leading to chorea? It's syndrome chorea is basically an improper movement of the arms and the legs, okay? Exacerbated movement. Okay, so you deserve to know why. On the bacteria itself, except of the M protein, there is also called gangliosides, okay? And the body starts making antibodies against gangliosides as well. Well, if you have antibody against gangliosides, gangliosidase, where it is located? In the brain. Where in the brain? In the basal ganglia. And thus you can have what? Syndrome chorea. Take a look at this chorea, guys. Look at this boy. See this improper movement of his legs and arms? Yep. Before you feel horrible, is this thing reversible or not? 100% reversible. All of the symptoms will go away. They will go away. So some people be like, wait a second, how can it go away if it's affecting a neuronal tissue? You know, it's affecting a neuronal tissue. How it can go away if it's affecting a neuronal tissue that we said it's a stable tissue? Guys, syndrome chorea mostly affect little children or adults? Children. All of the people you will see a photo of here will be children. All of them are children. Okay, the CNS of children, is it still growing or it's done, it will not grow anymore? Growing, so it will be able to fix itself. So that's the cool thing about it. Yeah, okay, let's go back here. So the treatment and the prophylaxis is with penicillin. For the step 1, you only need to know that it's penicillin. There is something called benzathine penicillin. You will learn it in the future in step 2. The idea in it is that you can give just one injection of penicillin for a couple of weeks or 3 weeks even, instead of giving like an injection of penicillin every single day. You know, that's painful. So John's criteria goes something like this. The J for migratory polyarteritis. What do I mean by migratory? It moves, guys, it travels. Once it's in his knee, second day it's in his hand, third day it's in his elbow. So it moves. Polyarteritis, it means that it affects more than 3 joints. And carditis, it leads to endocarditis, myocarditis, and pericarditis. It can affect any layer. Nodules in the skin, nodules. Let's take a look at the nodules. They are subcutaneous. They are not that deep. They look like little balls. They are not these at all. Yep, here they are. See, it looks bulgy, like you can put your fingers around it and even move it. It's cool. Okay, so you can see it here. It like to affect, if you have difficulty to find where it's affecting, search for a tendon, guys, okay? It likes to affect the area near the tendons. So, you know, in your hand here you have many tendons, so it like to affect that area. Okay, so let's go to the next one. They say Jones, so the E for erythema marginatum. So do not confuse erythema marginatum with erythema migrans. These two are totally different. Erythema marginatum is in case of rheumatoid fever, which you can appreciate here. If you take a look at it, it has big margins here, and in the middle, it's clear. There is nothing in the middle. You'll be like, no, there's a ring in the middle. No, guys, these are the edges, okay? There is nothing in the middle. These are just an edges to the rash. So you are like, okay, so what is this erythema migrans? Erythema migrans will be seen in Lyme disease. So erythema migrans will be seen in Lyme disease. It has the targoid lesion. So target-like lesion. You are like, oh, okay, so that looks like the one in syphilis. You are like, no, sorry, in herpes, no. The one in herpes, it has a targoid lesion, and there is so many of them, and they are really small. In Lyme, you have just maybe one or two, and they are ridiculously big, okay? That's how you differentiate between syphilis and the, not syphilis, what I'm saying, HSV and the Lyme disease. Okay, let's go back. So in Lyme disease, they are much bigger. Sydenham chorea, we said why they have it. Okay, so it all makes sense. Here I have all of the types of different erythema that are mentioned in the book. So Tinea corporus can lead, it's a ringworm that can have central clearing. Remember, this is due to a fungi. Well, we will speak about it later. Erythema marginatum, we just spoke about it. Keep in mind that it's not pruritic, it's not itchy. Erythema migrans, we said about it regarding the what, which disease? It was Lyme, yeah, Lyme disease. Multiforme, we will speak about it in the future a lot, actually, it's important. And erythema nodosum is associated with histoplasmosis and sarcoidosis as well, and it's most likely to appear on the shin, like on the legs, you know, and it's due to inflammation of fat, the erythema nodosum. Okay, syphilitic heart disease. Guys, do you remember when I told you about tertiary syphilis, and I told you it can lead to two problems, CNS problems and heart problems? So the CNS problem, it will make you happy. Wait, what? Yeah, it will make you really happy. Syphilis make people happy. Why? Seriously, I'm not kidding. This is not a joke. This is totally scientific. Why syphilis make the people affected with it really happy if it's tertiary? Interesting enough, the syphilis, when it enters your brain, the first area to be affected the first area to be affected in case of syphilis is the center of depression inside of your limbic system. So, when the center of depression in the limbic system is destroyed, you cannot be depressed. You will be really happy. Yeah? Sounds like a perfect deal. To make it even cooler, if you treat the patient and he destroyed the center of depression, he will never be depressed for the rest of his life. I know, sounds romantic. So, syphilitic heart disease, tertiary syphilis, disrupt the Vasa Vasorium of the aorta. What is Vasa Vasorium? Vasa Vasorium is a vessel that I told you about. It is a vessel that supplies your vessels with blood. Like your coronary artery supplies your heart, you need a vessel to supply your vessels with the blood. So inside of your vessels, there is a minor branch that goes out from the vessel to supply the vessel. That just like sounds weird. Okay, again. So there is a little vessel that goes outside from your normal vessel to supply your vessel. I hope it's not sounding weird. Okay, so if you have here a vessel, and to supply this vessel with the blood, there is a little channel inside of each of our vessels, and these channels have what in them? They have a blood. So blood is here, and then the blood starts supplying all of the walls. Okay, so in case of syphilis, the area that will be affected is what? Which one? It will be this one. Okay, the Vasa Vasorium. Okay, so Vasa Vasorium of the aorta and the consequent atrophy of the vessel walls and dilatation of the aorta and the valve rings. We spoke about this before. If you have dilatation of the valve rings, will you get a valvular form of regurgitation or an annular form of regurgitation? I love the person who wrote annular before finishing the question. Okay, so it will be annular. what is an annulus? What is an annulus? So annulus is just the ring that is around the valve, okay? So let me show you an annulus. Okay, so if this is a mitral valve, the leaflets are here, and what is around the leaflets is an annulus. So if we have dilatation of the heart, the annulus will be stretched, and that will lead to a regurg, okay? While if it was a problem in the valve itself will be regurgitating. So it's either the annulus or the leaflet in themselves. Okay, so so the next thing, it may see calcification of the aortic root, ascending aortic arch, and thoracic aorta. So again, calcification of the aortic root will occur, ascending aorta and thoracic aorta. Well, that does not sound bad. Well, look how it looks like. It's disgusting. So if you take a look at it, it looks like a tree bark, which is like a root of a tree. And that's how your aorta will start looking like. Let's take a look at it. Okay, so you can see syphilitic aortitis here. Look, it looks like a freaking dog was eating on it. Yep. Okay, yeah, so that's syphilitic aorta. Guys, I have a question. How is syphilis transmitted except of sex? It could be vertical, that's true, but you must know that it also can be, this is weird, I actually could not believe it until I did a deep research. It can be transmitted by skin to a skin contact, guys. Skin to skin contact can also transmit syphilis for you. Yeah, have a beautiful nightmares tonight. So, it can result in an aneurysm of ascending aorta. It can result in an ascending aorta aneurysm or aortic arch and aortic insufficiency due to the dilatation of the annulus. Yeah, so the annulus will be dilated, so you will have a regurg. So, good. The next thing is acute pericarditis. Let me give it a moment. One more thing about syphilis, guys. Syphilis can lead to problem in the CNS as well. A few things you must know about syphilis. First of all, the eyes. The eyes, we call it, somebody know what happens with people who have syphilis with their eyes? Look, what happens to the people with syphilis in their eye? Well, conjunctivitis is possible, but that's not the main thing. The main thing that their eyes will be not reactive to light anymore, okay? So if you look at their eyes, there will always be hypobion. No. It's possible, but it's not the main thing. But they basically in syphilis have something called prostitute eyes. It's called the prostitute eyes. So the prostitute eyes is something like this. It goes, oh yeah, cute. So it goes something like this. Their pupils, when you try to do accommodation of their pupils, yeah, also ergal pupils. So when you try to accommodate them, like you put a structure in front of them and you bring it closer to their eye will constrict, no problem. But if you put a flashlight on their face, it will not constrict, okay? That's why you might see like pictures from the Middle Ages of taking a light and putting it in front of the face of the prostitute. It's a common thing. And the reason is that her eyes do not accommodate, and if they do not accommodate, it means she has syphilis, okay? That's what was the way to diagnose ladies with syphilis. Keep in mind that they have this syphilis nose. I hope you remember how it looks like. This is just a quick feature you must know about. Yep, Voldemort had syphilis in Harry Potter. Okay, and yeah, so they have the saddle nose. It's like eaten up. Also, they can have one more thing you must know about syphilis is the nervous spinal cord. Yeah. spinal cord feature. So people with syphilis can have a posterior column affection. So their posterior column, the dorsal column, will be destroyed. If that is true, they will lose the sensation of a proprioception. In that case, we call it tabes dorsalis. Okay? So that's everything you must know about syphilis. When we reach it, we'll speak about it further. But syphilis is a really important disease. Not now, you will now rarely see it, but for the boards, it's important. So acute pericarditis, I showed you a picture in the beginning of our session about acute pericarditis and about the calcification around the heart. I hope you can appreciate here that between the two walls there is some free fluid. And that free fluid is basically the pericardial effusion. So acute pericarditis is an inflammation of the pericardium. So first of all, let's speak, what is the most common cause? Be careful with this one. It's idiopathic. Okay? If you have an answer saying viral, choose that one. So it's not uremia, it's not the STEMI, it's not the Dressler, it's not the most common cause. The most common cause is idiopathic or viral. Okay? So its inflammation of the pericardium commonly presents with a sharp pain in the chest, obviously, aggravated by inspiration. So when they take a deep inspiration, like they will feel pain in their chest. They even can halt their breathing because it's painful. How can they relieve the pain? Guys, they sit in a way that is quite characteristic. You see it and you are like, okay, I feel like Dr. House today. So you will see it and you will already start thinking about pericarditis, you know? So you take a look at the patient and they have this position. They are putting their hands on their legs and they are going forward. Why? Why this relieve the pain? Guys, look, the inflammation is in the pericardium, yes? And when they are doing this, they are moving forward. What are they doing? When they are moving forward, they are putting this layer, the gravity grabs this layer and pull it away from the other layer, which reduces the what? The friction between the two layers. Less friction between the two layers lead to less pain. No pain, no gain. No, I'm kidding. So yeah, that's why they like to put themselves a little bit forward so they will have less pain. Okay, so you can see here the visceral layer, and you can see here the pericardial fluid, and here you can see the what? The parietal layer. Keep in mind that all of the inflammation is happening in the serous pericardium, not the fibrinous. Fibrinous is not touched. Okay, let me send you this, guys. Okay. So the next thing we are going to discuss is, so they tell you that the pain will be relieved when leaning forward, often complicated by pericardial effusion. Between the yellow arrows, as you can see, here is the pericardial effusion. And it presents with a friction rub. I will send you today an MP3 recording of a friction rub. But if you are too confused about it, it sounds something like this. So why the leaning forward helps, guys? It's pretty important to know. Look, if we have a patient and he has the following problem. Look, so the inflammation is in his pericardium. Let's imagine that we have visceral layer. Let me make it in black so it will be more apparent. Visceral layer, parietal layer, okay? And in between we have what? The inflammation. Why do we have the pain in the first place? The pain happens because these two layers are like going against each other. Yeah, like this, going against each other. That's painful. So when you lay forward, your head goes forward, your chest goes forward. This layer, the visceral layer, is fixed to where? It's fixed to your heart. See? It's fixed to your heart. It's not going anywhere. While the parietal layer is mobile. So when you go forward, what happens to the parietal layer? It goes forward as well. This is fixed. This goes forward. So the distance between the two is larger. So there will be less friction. No more friction, no more pain. Does it make sense? The person who asked, did you get it? Awesome. Good. So we have here the following. It presents with a friction rub. ECG changes include widespread ST segment elevation and BR depression. You are like, wait a second, you lied at me. You told me that ST segment elevation was in case of like STEMI. Well, yeah, that was if it was in a constant leads, like for example in lead 2-3 AVF or in lead V1, V2. But what about if it was in every single lead in the ECG? You mean every single lead? Well, except AVR, but yes, all of them. So you are like, can you show me this? Well, it's a good time to practice our ECG. Let's see the ST segment and the J point. So, here we go. J point. You make a line. It's higher than the BR interval. ST segment. Good. Lead 1 has ST segment. Lead 2. Let's see. This is the J point. It's higher than the BR interval. ST segment elevation. Okay. Let's take a look at... Oh, sorry. What did I do? Oh, lead 3. Well, lead 3, QRS. Well, this one looks kind of normal. It's kind of normal. You cannot judge about it too much. Okay, next one. This one. High. This one. High. This one. Also high. This one. High. This one. High. High. See, most of the leads in his chest, even these, high, and this one, AVF, and the 3 are not. They are normal. But it's widespread. It's all over his chest. And when you see it widespread, done. If it's in most of the heart leads, done. You have a diagnosis. It's an acute pericarditis. Acute pericarditis leads to an widespread ST segment elevation. Okay? So look, sometimes you get confused, and I get it. Like you don't know if it's a ST segment elevation due to an MI or is it an ST segment elevation due to like pericarditis. You are like, well, it can be multiple arteries. Well, first of all, the presentation will be totally different. But if we say, okay, let's say you are right. Notice here, is the BR interval the same or is it depressed? The BR interval. Well, if you take norm is here, you can see that it's a little bit depressed. And depression of the, here it is, see? The depression of the BR interval is highly characteristic of what? Pericarditis. Okay? So, you can either see the widespread ST segment elevation all over the heart, or you can see the BR depression all over the heart. So we said the most common cause is idiopathic. It could be viral. Also, it could be due to some confirmed infection of Coxsackie virus. Guys, please do not forget, Coxsackie virus is an enterovirus, which means it can come using your ECG. Okay? And, oh, nice photo. Good. So, it's enterovirus, and since it's an enterovirus, it can go through your GI tract. And the other enteroviruses we have is poliovirus, and we also have the echovirus and Coxsackie virus. 3 viruses you must know. We'll speak about in microbiology in details. So, neoplasia can also lead to acute pericarditis. You are like, why? It's weird. Neoplasia, pericarditis, it does not make sense. Well, in fact, that when a patient has tumor, they can have this tumor lysis syndrome, if you ever heard of it. So some substances can be secreted and they can be accumulated inside of the body that can lead to pericarditis. We'll speak about one of them right now. Also, autoimmune causes such as lupus and rheumatoid arthritis. Well, okay, so rheumatoid arthritis, we know about this one. But lupus? Yeah, lupus can practically infect every single tissue in your body. Every single one. Joint? Yes. Liver? Of course. Kidney? Why not? Heart? Yeah. Brain? Yes. Testicles? Okay. Muscles? Why? Well, why not? Of course I can do that. Lupus can infect every single tissue in your body. Blood cells? It does. Leukocytes? Of course. So why it can affect every single tissue? Because the antibody made, they are against what? They are against what in lupus? Against what we are making antibodies? DNA. And all of your cells of your body, almost all of them, have DNA inside of them. And the one who do not contain DNA, lupus has 2 other antibodies just in case to be able to attack with them as well. So, okay, uremia, somewhat. Okay, guys, tell me, in which of the following patient will have uremia? Kidney failure or liver failure? Somebody, was it rigged? Look, where is the urea cycle located? The urea cycle is located in the liver. That is correct. And what is its function? Is to convert ammonia into urea. Yeah? So if someone has a cirrhosis or liver dysfunction, he will have accumulation of ammonia, not urea. So urea after that goes to which organ? Your kidney. Yeah? So when it goes to your kidney, it's transudative. So when it goes to your kidney, the urea, it's cleared there. Okay? So ammonia becomes urea, cleared by the kidney. So to get uremia, you should have kidney dysfunction, not to be able to clear the urea. If you have liver dysfunction, you will have hyperammonemia, not uremia. Yeah? I hope that makes sense. So to get uremia, you should get kidney problem, not liver problem. Okay, urea is high. What's the big deal? Well, when urea is high, it will go into your pericardium and lead to its inflammation. Okay, cardiovascular causes like a STEMI. It smells like a bee, exactly. So cardiovascular causes can be like, for example, in an acute STEMI. Do you remember, guys, in acute STEMI, we could have like this post-infarction pericarditis, and it was like 1 to 3 days after the infarction, and it was mediated by neutrophils, acute inflammation type of thing. I have a question. Which form of STEMI can it happen in? Can it happen in a non-STEMI or only in a STEMI? Can it happen in non-STEMI then? Can it be in the subendocardial? No, it cannot. Excellent. So because it's just an extension of the inflammation. So Dressler syndrome, can it be in a non-STEMI Dressler syndrome? Yes, both of them. Because Dressler syndrome is an autoimmune phenomenon. Yeah. So also radiation therapy. Well, why would I get a radiation therapy? Guys, radiation therapy is not a joke. It's really important for cancer treatment. Back in the time, they used to use it for acne, and they discovered it's a really stupid option. So, because they are like, oh, you don't have acne, you look beautiful, but you have thyroid cancer. So, that was a bad idea. So, the radiation therapy is mostly now used locally for certain tumors. They shrink the tumors, okay? They make it smaller. And the idea is like this. You focus the radiation at one area exactly, and that's the only area that you will have the tumor, you will have the focus of radiation at. It can be used a lot in brain tumors. This is what they do in brain tumors. It looks kind of scary as hell. See, this thing is fixated. The patient cannot move his head at all. And yeah, it basically tries to reduce the movement of the proliferation of the cells. It kills them. Gamma knife, all of these stuff are super interesting stuff. And yeah, one day hopefully I will see one of you working in this field. So, okay, so treatment. We have NSAIDs for acute pericarditis, but guys, I want you to know the following. The most likely NSAID that we use for acute pericarditis will be Indomethacin. Okay, it will be indomethacin. Indomethacin. And then the next drug to use is colchicine or colchicine, whatever you want to call it. And if these two do not work, you give the steroid. This thing is important. You must know that. First of all, these two, and this is a second choice. Okay. The only case that the treatment is different in a case is a case of uremia. Just remove that freaking urine from his blood. Well, urea from his blood. How? By dialysis. Okay? So you are meaning if I have in the option dialysis and I have NSAIDs in case of pericarditis due to increased urea, I should give just the dialysis? Exactly. So how can the scenario will be? They will give you a patient with a really high creatinine level, like 3 or 4. And then tell you that he has this friction rub and on inspiration he feels bad, when he lean forward he feels better, and you need to think about what? Acute pericarditis due to uremia. They ask you what is the treatment, it's dialysis. Okay, next topic and then little break, we study vasculitis tumors and finish up for the day. So myocarditis, and we will be done with pathology by the way, yay. And tomorrow hopefully we will be done with the pharmacology and we will finish up CVS system, the second most difficult system in the clinical ones. Guys, the most difficult subject for us will be biostatistics. It's only 6-7 pages. I'm really good in it, so I hope that I will be of value for you guys to explain every single point in it. Sadly, I know that it's 6 pages, but it will take 2 days to explain. And the next most difficult topic is CNS, not for all of the students. Personally, for me, it was a lot of fun, but some students find it really difficult. Most of the students, actually. So yeah, that will be a little bit difficult. I have some mnemonics, good stuff you can use, so I will help you with that. And yeah, the third most difficult is CVS. Some people say biochem. Biochem, I have good news and bad news, guys. So the good news that during June changes and alteration and of the bool, they reduced the amount of biochemistry asked on the exam to 2%. It used to be asked 7%, now it's only 2% of biochem. You are like, yay, I don't have to memorize eye cell disease and glycogen storage diseases. This is not true. The eye cell disease, Marfan, Ehlers-Danlos, all of this stuff, they do not consider them under biochemistry. They consider them to go under pathology. But yeah, you should know where eye cell disease happen exactly. Problem in the Golgi apparatus, not the rough endoplasmatic reticulum. So you must know exactly what you should not learn anymore like previously. Previously we had to memorize every single step in the nutrition cycles, like in the metabolism cycles, like these. You know, it was really painful to memorize all of these stuff. Now, luckily for you guys, they have reduced the question on these. So now they make only 2 to 3 questions of the whole exam. And to make it more fun, see all of this stuff, you will not be asked about. You will only be asked about this table. See this table? Yes. Print it, cut it, put it in your bathroom, and revise it every single day. All of your question on your USMLE Step 1 regarding metabolism will be from it. Okay. So moving back to CVS, let's finish GIT. GIT. No, let's finish myocarditis. Inflammation of myocardium. Okay, so how can I tell on the exam that I'm having a patient who has myocarditis? Look at the scenario. They will give you a young patient, relatively young, and they tell you suddenly he was having no problem, and suddenly he has a congestive heart failure septum. You mean like left heart failure and right heart failure? Exactly. So he will have dyspnea, chest pain, fever, he will have like the edema, he will have the GVD, all of that. He will have heart failure symptoms that occurred acutely, okay? Okay, they write, inflammation of the myocardium. There will be global enlargement of the heart and dilatation of all chambers. You are like, wait a sec, why there will be dilatation? Well, in case of myocarditis, it's inflammation. And inflammation will bring his amigo, macrophages. What macrophages like to do? eat. They like to eat. What do they eat? The myocardium. Wait, really? Yeah. What else? Neutrophils will come. What they will do? They will not eat. What they will do? Make a lot of free radicals. What the free radicals will do? They will dilate your ventricles. Is that a good thing? No, it's horrible. Which S are we going to hear? You have to tell me this. Which heart sound are you going to hear? Don't disappoint me, man. I'm telling you that there is dilatation of the ventricle. Dilatation, it's more thin. The wall becomes much more thinner. So the wall become more thinner. It's a dilated form of cardiomyopathy. It's an S3, okay? So S4 is for stiff ventricles, like hypertrophic. This patient have it dilated. Dilated is like thin. When it's thin, it's a 3. Thin for a 3. TH, okay? Thin, 3. Okay? So, major, well, actually, that's a good mnemonic. Never thought about it. Okay, well, here you go, guys. Thin, 3. TH. Done. So, major cause of sudden cardiac death in adults, less than 40. Okay, we just spoke about the less than 40 type of things. So, remember how an S3 sounds like. It sounds something like this. What about this sound? What is it? I will keep doing it until someone tells me what it is. They got really annoyed really quick. Okay, so yeah, it's an S4. Good. So presentation is highly yes. Okay, so S3 versus S4. Remember, guys, when I kept telling you about the following. So we have S3. Oh no, we have age 35. People who have less than 35 years of age, to have an S3, this is completely normal. People who are older than 35 years of age, to have an S4, this is completely normal. Okay? So let's go back here. Presentation is highly variable. It can include dyspnea, chest pain, fever, and arrhythmia, which include persistent tachycardia out of the proportion to fever and characteristic. What does that mean? Guys, does fever lead to bradycardia or tachycardia? If someone has fever, will he have tachycardia? Yeah. Tachy, exactly. So, but the patient tachy will be ridiculous in case of myocarditis. Like, it will be much higher than his fever. Like, he will have fever. It will be like 38 degrees, but his heart rate will be 150. It does not fit. So multiple causes can cause this myocarditis, including viral, most common cause. Adenovirus, Coxsackie virus, parvovirus. Parvovirus love people who have thalassemia and sickle cell. HIV can lead to myocarditis directly. You must know this. And HHV6. Does anybody know what that is? Human herpes virus number 6. It has another name. It starts with an R. It starts with the letter R. What is it? Ro. Come on. Somebody know? What is a human herpes number 6? Love children. Not Rota, man. Come on. Rota is not herpes virus. This is herpes virus number 6. Ro. I said R. How you said? How did you see? No, it's not Zoyster. I said R. Roseola. Roseola and Phantom. Come on. So Roseola. Rico. So yeah, Roseola, exactly. Okay. So keep in mind that this patient with roseola, this is really actually interesting disease, because you will have the child coming to you. He will have like the presentation is quite interesting, because you will get sued because of it. That's the thing. The idea is that the patient will come initially to you having ridiculous fever, 40 degrees. You will give him some anti-fever, antipyretic drugs, and you will send him home and tell him everything will be okay. Your child is perfecto. 2 days later, he has this rash covering him from the face to the toes. And she will bring her child back to you and be like, you said everything is going to be okay. And all of the child with all of this rash on his body. That's roseola. It's not a problematic, but just like worry the parents, you know? So, okay, anyway, so lymphocytic infiltrate with focal necrosis, highly indicative of myocarditis. When I say lymphocytic infiltrate, would it be mononuclear or multiple nucleus of the cells in myocarditis? Yeah, exactly. So it will be mononuclear. If you take a look at histopathology of the myocarditis, you will see so many mononuclear cells. You can see a few neutrophils here and there, but mostly it will be mononuclear cells, macrophages and lymphocytes basically. So there is an important thing to know. The gold standard for checking the myocarditis is a biopsy of the heart. But in reality, we are not animals. We will not do it for every single person. It's highly invasive procedure, and to do it, you have to penetrate the jugular vein and keep going down there to check it. It's highly invasive. We do not do it. In reality, we prefer imaging modality, like MRIs, for example. And why MRI, not CT? Because MRI is much better seeing inflammation. CT is not good at seeing inflammation. Okay, parasites that can lead to myocarditis include the Trypanosoma cruzi. Remember that one could lead, it was due to the kissing bug. And Toxoplasmosis gonorrhea, it was from the cats. So, bacterial causes of myocarditis, Borrelia burgdorferi. Do you remember what else Borrelia burgdorferi led to us in an ECG? Something really characteristic on an ECG. We kept speaking about it. AV block, complete AV block. Well, trust me, having a noise annoying you is much better than having a 12 gauge needle going through your jugular vein all the way to your heart. So yeah, that sounds romantic. So, yep, Mycoplasma pneumonia is also can be a cause of myocarditis. Remember, this organism does not have a cell wall, so you cannot use penicillin against it. You must use something that works inside of it, like a macrolide. Corynebacterium diphtheria, it almost does not exist anymore, this one. Why? Because of vaccination. But just for fun, you must know how it looked like in the throat. I really don't know where they found a patient who has this, but they give picture in the USMLE about it. And yeah, it's this one. See? So it have this grayish appearance, a grayish appearance of the throat. And when you see it, it's done. This is diphtheria. This is necrosis, basically. So, next one. Toxins. Toxins leading to myocarditis. Carbon monoxide. And, oh yeah, my favorite. Black widow venom. So, the black widow is what? The black widow is... no, not this one. Well, this will lead to different thing in my heart. Not myocarditis. So, anyway... A black widow will lead to, it's the spider basically. Yes, this one. See, it looks like the one who bit Spider-Man. And when it bites you, it has this toxin that can lead to myocarditis. Also, black widow, when it bites you, it can lead to necrotic lesion. And yeah, something like this. Here we go. So, and the next thing is rheumatic fever. I told you that rheumatic fever, the O in Jones, it can lead to endocarditis, myocarditis, pericarditis, all of them. Also drugs like doxorubicin and cocaine, your favorite guys. Yeah. And autoimmune. So autoimmune causes will be corona vaccine. It's funny because actually it's right. Well, look, I'm a pro vaccination, but as a doctor, you need to realize that yes, vaccination has some side effects and you need to deal with them. Getting a transient pericarditis due to Pfizer vaccine, for example, is much better than getting COVID itself. So it's not that bad of a deal, you know? So, autoimmune. Autoimmune causes include Kawasaki disease, sarcoidosis, lupus, polymyositis, dermatomyositis. We'll speak about each of these like individually. Complication include sudden death. Well, sudden death sounds bad. Oh yeah. Okay, arrhythmias, heart block as well, and dilated cardiomyopathy. Let me check if I taught something today. Dilated cardiomyopathy, what sound does it lead to in heart auscultation? ST3, excellent, good. So, yeah, exactly, guys, with the prophylaxis thing. You know, you need to be transparent with the patient. If he asks you, you have to tell him the truth, but still. So dilated cardiomyopathy, heart failure, mural thrombus with a systemic emboli. Why? Well, why do we have a mural thrombus? When you have a dilated form of cardiomyopathy, the walls will not be moving, they will not be contracting, so there will be stasis. Stasis will create an embolus. Embolus will lead to thromboemboli. Exactly, so stasis it is. And that leads to systemic emboli. Okay guys, let's take a smaller break now, really small break, just like 5 minutes. Come back, finish with vasculitis and heart tumor, and be done with cardiology pathology. Okay, the pathology of the heart. Welcome back guys, let's finish this up. Okay, vasculitis. Okay, vasculitis is the plural. First of all, guys, which form of hypersensitivity reaction are vasculitis? Is it type 1, type 2, type 3, type 4 hypersensitivity reaction? And it goes for type 3 hypersensitivity reaction, exactly. So all of vasculitis, it doesn't matter what is the type, it's a type 3 hypersensitivity reaction. So what does it mean, type 3 hypersensitivity reaction? It means, well, if you remember, type 1 hypersensitivity reaction, it's an IgE mediated, yeah? It's an antibody mediated, that was type 1. Type 2 is an antibody mediated, yeah? Antibody mediated. This IgE also histamine mediated, yeah? So type 3, it's an immune complex mediated. Type 4 is cell mediated, also called the delayed, cell mediated. So now we care only about the type 3. Type 3 is immune complex. Immune complex is composed from complement, antigen, antibody. So complement, antigen, antibody. Awesome. So if you have these three together, you have formation of what? Immune complex. Okay, so we have an immune complex. What's up with it? Well, this immune complex will travel in your circulation and then it will deposit in one vessel. And this vessel, when it deposits inside of it, it will go into the walls. And when it goes into the walls after the deposition, it will activate its freaking complement, leading to acute inflammation. So that leads to the vasculitis. So let's take a look at different types of vasculitis, what causes them, how they go. Yeah, so vasculitis, we have three main types. We have the large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Starting with the large vessel vasculitis. First of all, we have giant cell temporal arteritis and Takayachi Artherites. So if we speak about giant cell temporal arteritis, you must know one thing about this disease. This disease is super high yield. They love to ask you a question about it. The first thing to know that it's in a really old person, more than 50, okay? And it's in females. Why? Because, well, most of the vasculitis are in females, but especially this one, it will be always in a female in the US mainly. The patient will be complaining of unilateral headache. Why? We'll say why in a moment. And they will have temporal artery tenderness. Why? Well, it's a temporal arteritis. So, the artery that goes there is inflamed. And jaw claudication. We'll speak about jaw claudication. It means that when they eat, their jaw becomes painful. Okay? May lead to irreversible blindness due to ophthalmic artery occlusion. To be more fair with you guys, you must understand exactly what happens. If I show you the carotid artery, the carotid artery has many branches inside of your head. It has the internal branches and the external branches. As you can see, these are the external branches, and the internal branches goes inside of your head. So all of these are external, and you can see the internal one as well. But for us now, what is important are the internal one. The first branch to go from the internal one is the ophthalmic artery. So in case of giant cell temporal arteritis, one of the first branches to be affected is the ophthalmic artery, leading to an irreversible blindness. So anything that is a branch of the external carotid will be affected. But for us as a normal human being, two branches will be affected the most. The first one, ophthalmic artery. The second one, superficial temporal artery. Superficial temporal artery affection will lead to pain in the head, in the temporal area. It will be even tender. And the one that is in the eye will lead to blindness. Don't forget about the claudication. So, most commonly affect branches of the carotid artery, and you will see what? Granulomatous inflammation. Let me check. This disease is autoimmune. The granulomas, they will be caseating or non-caseating, guys. Non-caseating, of course, non-caseating. Excellent. So if you take a non-caseating, because caseating granulomas are only in case of infectious disease. Infectious disease lead to a caseating granulomas. Non-infectious disease can lead to a non-caseating granulomas. Quick examples include tuberculosis. Tuberculosis lead to caseating granulomas. If we speak about the autoimmune disease like Crohn's disease, it's a non-caseating granuloma. So you can see here where it is, focal granulomatous inflammation, giant cell arteritis. Okay. Yep, so you can see the lumen of the vessel, and you can see the walls of the vessel. You can see the vessel is ridiculously narrowed. And it's because of the granulomatous inflammation inside of the walls. Yep, so the main thing, guys, do you remember when I explained for you the ESR? Let me ask this. Sickle cell disease, does it lead to increased ESR or a decrease in the ESR? Of course you know it. So the banana joke, yeah, it worked. So ESR will be decreased in case of sickle cell, but in case of giant cell temporal arteritis, it will be high. Any case of vasculitis will lead to higher giant cell arteritis. So this is important. I told you this was the only condition that we use ESR for diagnosing actually. The other ones we just did it just in case, to rule out diseases. But we never used it to rule in diseases. We never used it as a specific disease. We always used it as a sensitive test, not a specific test. This is the only disease we use it as a specific test. Why? Because we do not have something better. So if the ESR is high and the patient has like the symptoms, like the claudication, the eye problems, like the visual disturbance, you already start the patient on a corticosteroid. This is the only time you will be required to know something about the dose in this book. You must know that you start a high dose corticosteroid, not a low dose corticosteroid. You are like, wait. So we even do it without confirmation, yes. And you must do it prior, like before you do the biopsy. Why? Because you will not even risk to wait for the biopsy result to come back. Because you might wait just a little bit more, irreversible blindness, done. So high-dose corticosteroid prior to temporal biopsy to prevent blindness. Okay, let's say that you did the temporal biopsy and it was negative. Will you continue the patient on the steroid? Let's see. Yes, you will continue him on the steroid. The reason is that the biopsy has a really high chance of being false negative. Why? Because the temporal artery is long, guys. It's like this. So the temporal artery, if you take a look at it, it's long. It's like this. So if I take a section of it, like right here, yeah? I took a section right here. It might be clean, but it could be the problem is here, or even here, you know? So we take multiple sections, but even if they were all negative, you continue the treatment regardless. You don't want to risk getting hair blind. This disease is highly associated with something called Polymyalgia Aromatica. What is Polymyalgia Aromatica? Oh, it's not mentioned in this. Okay, so I believe Polymyalgia Aromatica will be an MSK. Really quickly, just take a quick look at it, just to be like have good association. So when we speak about Polymyalgia Aromatica in the future, we will go back to giant cell temporal arteritis and speak about it again. You know, so. Here it is. You can see Polymyalgia Aromatica. In this patient, there is pain and stiffness of the proximal muscle, including the shoulder and the hip. They love to tell you in the exam, in any patient who has a problem in their proximal muscle, that they cannot reach an upper shelf, okay? They cannot reach a higher shelf, and they cannot also do what? Comb their hair. They cannot comb their hair, okay? Exactly. It's often with fever and malaise and weight loss. It does not cause muscular weakness though. It's just like stiffness. So more common in ladies more than 50. It's associated with giant cell temporal arteritis. As you can see, again, there is high ESR, CRB, but normal CK. And the difference between this one and the giant cell temporal arteritis, you must know that this one is treated by a low dose steroid, while giant cell temporal arteritis is a large dose steroid. This is the areas of the pain. This is like a proximal muscle weakness, yeah? Okay, let's go back. Okay, so we have the next disease will be Takayachi Artheritis. Takayachi Artheritis goes something like this. So, if the patient only have Polymyalgia Aromatica, you give low dose steroid. If the patient has giant cell temporal arteritis, you give high dose steroid. If he has both, you give high dose steroid. So if he has only Polymyalgia Aromatica, you have to give low dose steroid. I hope it makes sense. Okay, Takayachi Artheritis, it's usually in Asian. Well, no shit, look at the name, Takayachi. So Takayachi usually in Asian females less than 40. And you must know about one thing regarding this disease. This disease has super interesting fact that the patient, when you check their pulses, you will not be able to feel it, okay? Why? So the idea is like this. You check their pulses in the upper extremity, and there is a granulomatous narrowing in their proximal vessels. See here? If you can see, this is the arch of the aorta, and if you notice here, there is a blockage of the subclavian, for example, yeah? And that leads to absence of the pulse, or a really weak pulse. So they call it pulseless disease. Weak upper extremity pulse. They can have fever, night sweats, arteritis, myalgia, skin nodules, and ocular disturbance. The most important for you from all of these are the following: the pulselessness, being Asian, and the type of inflammation inside. You must know that it is also a granulomatous thickening and narrowing of the aortic arch. It's granulomatous. So far we have two of them that are granulomatous, giant cell and Takayachi. Okay, So, and the ASR will be high. The treatment, again, is a steroid. So done with giant cell, done with the large vessel vasculitides. What about the medium vessel vasculitides? Look, guys, I hope we have smokers in our group. So we have the next disease called the Buerger disease. I cannot say the name many times. I have an accent. So I say Thrombonditis Obliterans. So it's in heavy smokers. And these heavy smokers, mostly males, less than 40. More than 40, less likely to get it. They have intermittent claudication, which means like when they move, when they walk, they start feeling pain in their legs, okay? Like angina type of thing. And in their fingers as well. It can lead to gangrene. Look at this. Oh yeah, it's cute. So, the Thrombonditis Obliterans, the most common cause is the smoking. Let me just... It's a form of thrombongitis, and the main thing is that the vessels are just getting occluded because the patient is a freaking smoker. And you can see how bad it can be. It can go so bad, guys. It can go so bad that the patient will fall down, you know? It's just crazy. You see how their fingers, like because they are just such an avid smoker, they will start losing fingers like this. And to make it even worse, it's painless. So they see their fingers falling in front of them. It's okay. Like they want to smoke. Yep, don't smoke. Heavy smokers, males, intermittent claudication may lead to gangrene, autoamputation of the digits, superficial nodular phlebitis. Okay, Raynaud phenomena is often present. What is Raynaud phenomena? Raynaud phenomena that happens, it's basically vasospasms upon exposure to cold. The only treatment for the patients with the Thrombonditis Obliterans is a smoking cessation. If they stop the smoking, everything is reversible except if their finger is lost. You cannot reverse that. For Raynaud phenomena, on the other hand, the treatment is calcium channel blocker. For the Thrombonditis Obliterans, it's not calcium channel blocker. Do not make that mistake. So Raynaud phenomena, calcium channel blocker because it vasodilates the vessel. Okay. Do you see it? Oh yeah. Mostly when they are exposed to cold. Okay, so what you are going to see, well, I kept telling you it's a phlebitis. What does a phlebo mean in Latin? It means vein, okay? So it's a segmentally thrombosing vasculitis with vein and nerve involvement. Why it's important to know that there is a nerve involvement? Because I just told you guys it's painless. They don't feel all of this process happening. And the treatment, just tell them to stop smoking. The smoking is the main problem. So just to stop the smoking, everything is reversible except if you lose a finger. Okay, the next disease, they love to ask you about Kawasaki. Every single one of you guys is going to get a Kawasaki question. So it's better to get it now than to get it later, because you will have to study it eventually. So it is in Asian children, less than 4 years old, and they will have the following. Conjunctival injection. Well, that's easy. What else? Rash. What type of rash? Destigmatizing rash. Well, how does that look like? You really want to see it? Yes, you do. You are doctors. You must see it. They can have two types of rash, destigmatizing and petechial rash. You must know about both. This looks more like the petechial rash. And they also can have destigmatizing rash mostly near their extremities. Near their distal extremities. That's the destigmatizing rash. So, petechial rash on the trunk, destigmatizing rash on the periphery. Yes, it can occur after COVID as well. Okay, so the next thing here is adenopathy, cervical adenopathy. But the most important, and what they like to show for all of the students to try to trick them, is what? The strawberry tongue. So they show you the strawberry tongue, which looks like something like this. Beautiful, strawberry. So what is not beautiful? When you see the strawberry tongue, you need to be really comfortable with the idea of its relationship with two diseases, not one. The first disease is Kawasaki disease. The second disease, excellent, it's a scarlet fever. So the scarlet fever is also can cause it. So how can I differentiate between the two? The first way to differentiate between the two is the rash, okay? So, yes, okay, the fever for 5 days, that is also correct. So the rash. If you speak about the rash, how does the rash appear in case of the scarlet fever? Sandpaper rash. We say sandpaper rash. What does it mean, sandpaper rash? Well, sandpaper. For all of my fellows who worked in construction previously, I love you guys. So yeah, it's like this. This thing, we use it to like do the walls. It's horrible because it gets all of these small particles into your lungs, but who cares? All of us need to make cash. So sandpaper rash, the feeling of it when you start touching the skin of the patient, it feels the same, like the sandpaper, okay? So that's interesting. Okay, so if you see sandpaper plus strawberry tongue, that is equal to scarlet fever. If you see a batica rash or a sequematizing rash plus strawberry tongue, you think about what? Kawasaki. So this is different forms of strawberry tongue. Strawberry. Okay, good. Guys, by the way, in real life, it's associated with COVID, as one of you said. It's really common these days. So, and you must know how to treat it. You must know how to treat it. Okay, so hand-foot changes will occur, such as erythema, edema, and also fever. The edema is important. It's the most important thing. You must know that they have this hand and foot edema. Okay? I want you to know about one thing also regarding Kawasaki. Just a second, I want to show you the edema. Yeah, you can see the edema on the palms and soles. It's not the only disease. So, a crash and burn on a Kawasaki. Okay, so they imagine like this motorcycle called Kawasaki, old company. And when they hold this motorcycle, the Kawasaki, you have involvement of the palms and soles. And it leads you to get burned, which is like the mnemonic, which I don't like. So, it may, this patient, if a patient comes to you, he's like 5 years old or 3 years old, and he has an MI symptoms, and you do an angiography on him and you see freaking aneurysm in his heart. That you have a diagnosis, it's Kawasaki. That's why they die, okay? So why they die, if they ask you, they die because of heart attacks. Like what? Heart attacks? How come? Well, how can an aneurysm lead to a heart attack? Look what happens, guys. So, if we have a coronary artery, okay, if we have a coronary artery like this, okay, and it has like, I'm bad at this, let me just use this one. Okay, you have coronary artery and it has various aneurysms inside of it, so there is some dilatation here and there, here and there, here and there. And what occurs? See this area, it has kind of a stasis inside of it, yeah? And this aneurysm, like all it takes is just a little endothelial wall to rupture. And when it ruptures, what happens? Well, what happens is basically hallelujah. Thromboses start occurring all over the place. Done. You got an MI. So, since the aneurysm lead to a weakened wall of the coronary artery, they predispose you in getting rupture of the endothelial cells, exposure of the subendothelial collagen, which lead to it binding to the von Willebrand factor, if you remember, guys. That binds to the platelets. Platelets bind to the platelets. That lead to aggregation, and that leaves you an MI. Okay, how do I treat such condition? You can treat such condition by giving IV immunoglobulins and aspirin. So, someone wrote it's the only disease that we give aspirin in. There is one more disease you have to know for step 2, not step 1. But just for fun, I will tell it for you. Juvenile idiopathic arthritis. It's for step 2, not step 1. So only 2 diseases we give aspirin for: Kawasaki disease and juvenile idiopathic arthritis. Okay. So that was Kawasaki. The last disease in the medium vessels vasculitides include something called polyarthritis nodosa. It's usually in a middle-aged man. And here it is interesting. Why? Because in different diseases, I told you that all of them are an immune complex type of diseases. But for so far, all of what we have spoke about, you were not required to know the antigen and the immune complex, you know? I did not tell you which antigen in each of these. It's not important. You don't have to know it for the USMLEs. But there is this one that you have to know. For polyarthritis nodosa, the antigen is the hepatitis B surface antigen. This is the antigen. The antibody is an IgG. And the complement is the complement. When you get these 3, you got yourself an immune complex. So, polyarthritis nodosa, usually in a middle-aged man. Hepatitis B seropositivity in 30% of the patient. They have fever, weight loss, malaise, and headache. The most important thing to know about this disease that it does not involve the lung. Okay? If you have any form of vasculitis and you'll be like, oh, this is a vasculitis, and it does not involve the lung, and it involves the lung, it's not polyarthritis nodosa. Before moving forward, I would like you guys to know the general symptoms of vasculitides. If someone with vasculitis has a rash, which is quite common in most vasculitis rash. If you have a rash in case of vasculitis, and I bring my finger and try to push on it, will it disappear? Exactly, it will not disappear. It will not disappear. This is really important finding. Non-blanching, it does not blanch. If it blanches, it will be due to a thrombocytopenia, yeah? Due to a thrombocyte problem. But if it does not blanch, it means it's a vasculitis. See, from your finger, you can differentiate between the diseases. Yeah. So, if you push on it and it does not disappear, this is vasculitis. If you push on it and it disappears, that means it is a thrombocytopenia. Okay, usually in a middle-aged man, we said that GIT problem include abdominal pain and melena. Melena is black stew. Hypertension, neurological dysfunction will be, cutaneous eruption as well, and renal damage. Notice, nothing about lung. So typically involve renal and visceral vessels, and you must know what they cause in the vessels. If you take a look at this picture, they have like little microaneurysm inside of the kidney. We just saw something like this in Kawasaki, but the microaneurysm were not in the kidney. They were in the heart, okay? So you must know the cause. It's a transmural inflammation with fibrosis. You are like, okay, so why it's leading to an aneurysm? Look what happens, guys. What happens actually that there is an area of fibrosis. Then there is area of nothing, normal tissue. And then again, an area of fibrosis. So the fibrosis is much stronger than the normal walls, so they dilate. Again, the same story, fibrosis, normal walls, that dilates because of the pressure. So it leads to a beads on a string appearance, okay? So different stages of transmural inflammation with fibrinoid necrosis. Guys, what other disease has fibrinoid necrosis in it? Let's see the type A student. What other disease has fibrinoid necrosis in it? Hypertension, okay, and preeclampsia. Good. So, here they write for us, there will be an innumerable renal microaneurysm and spasm on arteriogram, string on barrels appearance, which I just showed you here. And you can also see it here. like little aneurysm all over the place. Yeah? Okay. You must know what is the treatment. Treatment is with the steroid and cyclophosphamide. Okay. So these are the three diseases: Thrombonditis Obliterans, smoker, stop the freaking smoking. It's associated with rhinoid phenomena. Kawasaki, little children, they have this MI-like symptoms and microaneurysm in their heart. Next disease, polyarteritis nodosa, associated with hepatitis B. They have renal involvement mostly with microaneurysms in their kidney. They do not have any lung involvement. The next group of diseases are the small vessel vasculitides. Small vessel vasculitides. The first one is Batchet disease. You're like, wait, is this Batchet disease? No. This is Batchet disease. It's different. So because there is Batchet disease of the bone, Batchet disease of the breast, and now Batchet disease, Batchet syndrome. So many similar names, totally different pathology. So high incidence in Turkish and Eastern Mediterranean descent, recurrent aphthous ulcers, genital ulcerations, and uveitis. So these patients will have the following. They will have the following problem. They have ulceration at different organs. So these organs include aphthous ulcers, like in the mouth, on the genitalia, in the eyes, in the vagina. So in the vagina, that's important actually. They have dysphagia. Why? It's painful for them to eat. They have dyspareunia, dyspareunia means painful sexual intercourse. Why? Because they have ulcers down there. They have like this eyes that you look always at them and they inflamed. By the way, I just want to teach you how to be able to look at the uveitis and know that it's a uveitis just from a look. Just a second. Okay, so you see this eye, you are like, well, I have no idea if this is a uveitis or is it a conjunctivitis. How can I differentiate? Well, it's pretty simple. Look, I hope I can find one more. Yes, here it is. Okay, this one is good enough. And these are good as well. So, what is the uvea first of all? Uvea is the iris and the ciliary body and the choroid together. So choroid together with the ciliary body and the iris, we call it uvea. So it will be inflamed. So this guy will be inflamed. If that is the case, what you will see in the patient eye? You will see uveitis. I did not get it. Well, now you will. Let me use blue. I told you, you will see what? Uveitis. So if there is a hyperemia of the vessels around the iris, that's uveitis. So it looks like a uveitis, okay? Good. So the next one is erythema nodosum. That will occur in the patient with Batchet disease, Batchet syndrome. And the erythema nodosum is basically an inflammation of the fat, the subcutaneous fat, okay? So let me show it to you. It's also associated with autoimmune diseases such as sarcoidosis. So you can see here the inflammation of the subcutaneous fat. We also call it paniculitis, okay? Which is what? Inflammation of the subcutaneous fat. Okay, we'll be asking you after the class in the tests. So, can be precipitated by HSV, which is herpes, or our amigo, parvovirus. Okay, it flares. So here is the thing. The patient has flares. It appears, disappears, disappears. And each flare lasts 1 to 4 days. You must know that it's an immune complex vasculitis, like all of them. And it's associated with an HLA-B51. There is a few HLAs you must know about, okay? Including HLA-B51, HLA-B27. HLA-B27 is associated with the Bayer mnemonic, okay? What is that? Psoriasis, ankylosing spondylitis, inflammatory bowel disease, reactive arthritis. You must know this one. HLA-B27, HLA-B51. HLA-C. Okay. The next disease is cutaneous small vessel vasculitis. So cutaneous small vessel vasculitis is affecting the small vessels. It occurs at 7 to 10 days after a certain medications. The few medication cause it, not many medication, including penicillin, cephalosporin, both of them are beta-lactam, phenotine, and allopurinol. Well, this allopurinol, I'm seeing it that it causes so many side effects. Interstitial nephritis, well, it can cause that. Can cause to this cutaneous small vessel vasculitis. It can lead to like sulfa allergy problem. I mean, come on, allopurinol, chill. That no wonder they are starting to change it with febuxostat. Infections also are associated with cutaneous small vessel vasculitis. Be careful. It's hepatitis C here, not hepatitis B. Hepatitis B was polyarteritis nodosa. Hepatitis C and HIV is cutaneous small vessel vasculitis. Keep in mind that it's in the name, cutaneous. So this disease does not involve internal organs, mostly. Sometimes it can, but on your exam, it will not. They will just tell you about someone who took penicillin, for example, or took allopurinol, and after that he has a non-blanching mass, non-blanching burbura. It's palpable, you can feel it, but you cannot, if you press on it, it does not disappear. So it's mostly in the skin. They write for us, it's an immune complex mediated leukocytoclastic vasculitis. Late involvement indicates systemic vasculitis. It can lead to systemic vasculitis, but in your exam, they will just tell you about the cutaneous finding, and I told you it does not blanch, and it's associated with taking a drug before it. Okay? So let's just take a look at that. Yes, you can see it here. This one. Okay, let's go back and see what do we have left. Okay, so the next, here we come. So let's speak a little bit about the Nazis. So there was these Nazi scientists. The first one is called Schurg-Strauss, second one is named Wegner, and the third one was Henschenblon. 3 Nazis. They discovered many diseases, and after their discovery of these diseases, they published them. And after they published them, I know this is a boring story, but they keep like repeating it, so I have to repeat it. Sorry, have to suffer. So these Nazis kept doing their experiments on really human beings, okay, like living human beings, not even like animals, then doing it in a human. Well, let's do an autopsy on a dead person. Why? We have a living one. It's much easier. So anyway, really messed up people, but they discovered a lot of things. They died. After they died, their books and their knowledge stayed. And regardless of the fact how horrible way they found it, it exists. And it's useful for us. That's why we still use it. But in the recent year, why I'm telling you this story? For you to know, guys. On your test, you might see this name instead of Schurg-Strauss. They are trying to remove the Nazis' name from the book. Schurg-Strauss, Wegner, Henschenblon, they are trying to remove the names. So, you must become more comfortable knowing the other names, since they can mention the other name and not mention for you the scientist name. And if you don't know the other name, you lose the question. So be careful about that. Eosinophilic granulomatous with polyangiitis, also called Schurg-Strauss. It has eosinophils in the thing. So you must know if it has eosinophils, it's the one with asthma. Because you know, in asthma, you have high eosinophils level. Okay, so in Schurg-Strauss, they have involvement of the sinuses. So they can get sinusitis. The skin issue, like always, but what is important for you guys? It can lead to wrist and foot drops. Write this down. Why? Because of the mononeuritis multiplex, affecting the epineurium. What is that? The nerve itself contains the 3 layers. The outermost layer, called the epineurium, that gets inflamed in case of eosinophilic granulomatous with polyangiitis, leading you to have palsy of different peripheral nerves. You must know this. Okay, so the next thing you must know that it can involve the heart, GI, kidneys. But here is the thing. It's Pauci-immune glomerulonephritis. You're like, wait, what does Pauci-immune mean? It means when you look at it under the fluorescent light, you will see nothing. Pauci. It's transparent. While in contrast with other diseases, it will be like saying granular shaped or linear shaped. Some of you don't have any idea what I'm speaking about. That's why I'm going to show you kidney fluorescence. Okay. See this? If you take a portion of the kidney, put a dye on it, and a fluorescent dye, and then put it under microscope, you will see something like this. Pretty cool. That in the future, I will help you to learn how can you look at this one and know which disease it is. Okay? It's about the patterns. Don't worry, it's not that difficult. So, let's go back here. So, patient with Church-Strauss, they will have this neuronal problem, asthma, we said the problem with the heart, GI, kidneys, but the kidneys, we said it will be Pauci-immune glomerulonephritis, which we'll speak about more in renal. So, granulomatous necrotizing fasciitis with eosinophilia. Okay, so they will have eosinophilia. So you must know which, in the new book, names already hidden. See, I told you. So it was a matter of time, actually. Okay, yeah, so already they got rid of them. I was suspected it. Yeah, okay, good. So see, now they are hiding it, and then after some years they will make it disappear at all. So be careful. It's not about anything, but just like imagine going to the exam, knowing like Wigner, Church-Strauss, you go to the exam, you don't find these names. It's just like you will get messed up. So you must know that Church-Strauss is associated with MBO, ANCA, and B-ANCA. You are like, what is ANCA? It's anti-nitrophil antibodies, okay? So these anti-nitrophils antibody, we have two types of them, B-ANCA and C-ANCA. So what is ANCA? Anti-nitrophil antibodies. So notice, yes, okay. You can see B-ANCA. What does it mean? It's in the cytoplasm, the antibodies will be. Well, what about C-ANCA? The C-ANCA will be more deep. They will be near the nuclei on coloration. Do you have to know the coloration thing? No, you don't. You just need to know C-ANCA and B-ANCA. That's what is required from you. So, it's an IgE will be high. Why? Because eosinophils are high. So the B-ANCA is the anti-nitrophil metalloperoxidase. So you can see MPO stands for metalloperoxidase. The P is for B-ANCA. Okay? Good. Okay, guys. I apologize from you. I have like an appointment at 9 p.m. I cannot be later than this. So yeah, we have just a little bit left, like half of a page here, half of a page there. We'll be done with pathology. Tomorrow, when we continue, we'll finish up the whole cardiology. And I will see you tomorrow at the same time. Thank you so much, and see you tomorrow. Bye-bye, everybody.